Hi there, this is Dr. Kathryn Dao reporting for Room Now. I am so excited to introduce you to my friends. We are the lupus panel for Room Now, covering ACR 2021 convergence. Unfortunately, we can't be in San Francisco, so we're going to bring San Francisco to you. Why don't you all introduce yourselves? Janet, you want to start?
Janet Pope, London, Ontario, Canada, and I am at Janet Burdope.
What about you, Pete?
Pedro Castillo, or Pete Castillo. I'm out here in Dallas, and I'm at _Castillo_Pedro.
Bella?
Hi, I'm Bella Mehta. I'm from New York, and I'm at Bella_Mehta.
And Yuz?
Hi, I'm Yuz Yusof. I'm from Leeds, United Kingdom, and you can follow me at Twitter handle at Yuz6Yusof.
So welcome, everybody. I just wanted to go ahead and launch into the questions I have for you. What's some of the most exciting things you've learned so far, and how do you think it's going to impact your practice? And I guess we'll go in order again with Janet, but feel free to pop in if you want.
So I'll say two things. So the first thing is it's abhorrent that our patients with lupus are doing worse, and someone else will probably talk about the plenary. So the other session that I watched was basically if you were hospitalized for your lupus, a benchmark would be seeing a physician for follow-up within 2 weeks, and 2/3 of lupus patients didn't. And that doesn't surprise me because I think there's a huge communication barrier. We don't even know they're in, not to mention release from hospital. But it was trending, and more than trending, it was significantly related to non-white, poorer people, things like that, that would be low health literacy and probably low literacy. So I think we can do better. And why does it matter? Worse outcomes if you're not seen and follow up.
Yeah, I think just to follow up with that, Janet, I think we don't have a lot of rheumatologists everywhere to even refer. Like most rheumatologists have a wait time of 2 to 3 months, which is also not something that they presented in the abstract, but I think it's also important. There's a deficit of rheumatologists seeing lupus patients too.
That's right. Although if it's your patient and you knew they were in hospital, I think we'd call them in. We don't always know. And the patients might not know to advocate for themselves.
That's true.
What do you think about the trends in mortality, lupus nephritis mortality, particularly in the plenary session?
Yeah, so it is interesting, the data that were presented. It was looking into 20 years span, and you can see there was a significant, more than 20% reduction from 1999 to 2019. But the last 5 years of that period, there's slightly, increased. So I think this is slightly different trend compared to, I think, previous study reported by them. They said continuous, decrease. But yeah, but that's quite promising. That 20% reduction in mortality. I think that's quite good that we are advancing in our therapy.
Yeah, I found it interesting how there was a correlation between large metro areas and worsening mortality. That was very interesting because you would think that in the city you have more access, and that maybe in less when there's fewer rheumatologists and more rural communities you might have more trouble. But it was actually the opposite, particularly for Hispanic patients in the large metro areas, and for Black patients in general.
I think again, we've done some work on this before, and I think there's a lot of, especially in urban areas, there's a lot of pockets of low socioeconomic status.
Yeah.
And that probably accounts a lot for this. It's not just the race. I mean, obviously it is, but I think there's a lot of other factors that play into this.
Right. And it's different from Canada. Our patients tend to do worse if they're rural than urban. And maybe it's because we sort of have universal health care. But I agree. I think English as a second language, new immigrants are more apt to go to the large centers. That's where some of the work is. And this can't all be accounted, the racial differences, from genes alone. The odds ratio of being Black and having worse lupus nephritis outcomes was 6 times higher. We don't have many genetic things that in a polygenic disease that would account for that. So it has to be system problems. I think unexpected or unknown unconscious bias where our patients are getting differential treatment. We don't want to say that, but it's probably true.
And that's only amplified with the pandemic. There was an abstract about, lupus deaths during the pandemic, and we did see an increased risk of deaths and morbidities associated with the pandemic for sure. But I'm going to turn your attention next to the great debate. What do y'all think? That was pretty exciting, wasn't it?
Yeah, I really liked the idea of just, Dr. Petrie had mentioned at one point, I'm going to misquote it, but she said something like, I want us to change and I want to change in my practice. And I thought that was important because I think there's a lot of resistance to change. We get very used to certain types of medications, certain types of prescribing patterns, and trying to think not even outside the box, but within the box of, good information, good data for lupus nephritis and using belimumab and voclosporin. So I thought that was fascinating. And it was more supportive, I think, of both. I think Dr. Petrie did a great job, and so did Dr. Rovin, I believe, in sort of presenting both cases.
And I quite like how she finished it as well, saying like, we are actually really best friends and colleagues in the end, rather than debating which drug is which. And it's quite interesting that she also pinpoint a few aspects like potentially that may render you to choose one or another. I mean, it's all about personalizing therapy. I mean, it could be depending on the patient's EGFR state, and whether is there any extra renal flare there as well, which may influence which one that you want to choose. So.
I think as well, it continued on in the hub. Both Doctors Wolsey and Eisenberg were talking about voclosporin versus belimumab and lupus nephritis. And some really neat things were brought up, like what do we do with class 5 nephritis, so nephrotic syndrome, we're probably under-treating it. What about the cost effectiveness and lack of access? What about the burden on the patients, but of pill burden and adding more things, and really frankly cost burden? And the other thing that came up was in the question and answer is, what about treating interstitial nephritis? And I don't think we have any answers to that. And then someone raised the fact that there's case reports of 6 patients out of 66 on belimumab therapy with lupus who developed lupus nephritis, and in-depth discussion of chicken or egg, the same way TNF inhibitors, you can have RA or psoriatic arthritis and get worse psoriasis or new psoriasis, even though it treats it. So there's confounding channeling bias, and how could we do a study to look at that? But the bottom line is we have to do better. Most of our patients are not in complete renal remission. And over time, how long do we treat? We don't want to over-immune suppress, but backing off a treatment could be dangerous too. So it was really, the hub was great.
What about you, Bella? What do you think?
I think the debate sort of got us thinking, saying these patients are not the same. There's different phenotypes of these patients. There's different genotypes. And I think the only way to get around this is precision medicine going forward. So which patient gets what drug? Depending, some patients probably will develop lupus nephritis because they were always predisposed to. It's a chicken and the egg, like Dr. Pope said, but still, maybe it was the drug in that particular patient which caused it. So it's about patient selection, and as precision medicine gets finer and, in the next 10 years, I think we'll see those things actually happening. There's a lot of there's like all these prelim data out there that I see in the next 1 or 2 days, which probably go towards that. There's a nice session today, which I think would be helpful and insightful on that.
So let's take a vote. I put this out on Twitter just recently. You got a patient who has class 4 nephritis. They're already on hydroxychloroquine. This is biopsy confirmed that this is class 4. So aside from steroids, what are you going to do next? Are you going to add mycophenolate by itself? Are you going to do cyclophosphamide by itself? Are you going to do mycophenolate with belimumab or mycophenolate with voclosporin? Go for it, Pete. You take this. Which one?
You have to go with me first. I think that Dr. Petrie made a good point of trying to elect for early combination therapy. I mean, mycophenolate first, and depending on the severity of the case, as in this case, maybe even pushing with belimumab as well from the get-go.
So that's your vote, mycophenolate with belimumab. What about you, Bella?
What's the race of the patient?
It doesn't matter, but it's a person of color. How about that? They tend to have more aggressive disease.
I guess I'll still go with CellSup first, look for it a little bit, and then add belimumab.
After how long would you add?
2 months, 3 months, 2 months.
2 or 3 months? What about
2
you,
months.
Janet?
Right. So basically, it's an access issue in Canada. So I'm starting upfront combination, not with your choices, of course, steroids, MMF to 3 grams, and often adding tacrolimus like within the first month or two, once I know there's tolerability. Why tacrolimus? Because we can get cyclosporin. We don't have voclosporin available yet, and belimumab, it's very difficult to get access, but I'll take anything because I think 2 drugs of immune suppressives in lupus nephritis are going to be better than 1, steroids aside, might allow us to steroid spare better. So I'd answer your poll, probably any of them, just get on with it and get probably 2 drugs into them.
You're so diplomatic. What about you, Yuz?
Right. So yeah, again, similar as Janet. So I think it depends, what I want to treat and how, what I'm available, to treat the patient will be different, in the UK with National Health Service. I mean, for instance, like the belimumab, I mean, the trial was positive back in 2011, and we could only use belimumab in 2017 in the UK. So, that's quite a long journey to get a drug, funded. So I think in this case, I would start patient on mycophenolate and steroid, and then after that, I will assess after 3 months. And if you're not achieving complete response, then I will do an add-on therapy, and I will actually choose voclosporin here because of the rapid steroid reduction that it will show, and also remarkable complete renal response rate in the trial, which is like 0.5 proteinuria. I mean, that was quite high hurdle bar.
That is nice. And the fact that voclosporin had podocyte protection as well. But I've actually used the combination of belimumab and voclosporin and mycophenolate all together with hydroxychloroquine in a patient to finally get her to achieve renal remission. Well, that's it, folks. Thank you for watching us. This is our lupus panel. Room Now. Follow me on Twitter at KDao2011, and we'll continue to report to you with this conference, ACR 2021 Convergence.